Hi, this is Hady Lichaa, interventional cardiologist, covering the topic of coronary bifurcation strategy for left main and non-left main interventions. Of course, this is a topic that is very special to a lot of interventional cardiologists. This is where most of us kind of differ in opinion, and this is where some of it is related to more the art of the intervention rather than pure guidelines. But I'd like to share with you my own personal simplification and a practical approach to coronary bifurcation interventions that will hopefully help you. But of course, I'm open to any feedback and comments. So my own simplification of all the bifurcation strategies is inspired by the European Bifurcation Club document that was just published last year, with basically a further simplification into only two different bifurcation stenting strategies. So whenever we're facing a Medina 111, both left main and non-left main bifurcation, we obviously, most of us follow the sequential provisional approach, which we will detail in the next slide. But the natural progression of this is that if you have a dissection, the side branch that is symptomatic or is causing EKG changes or hemodynamic abnormalities, or the patient's having chest pain, then you move on naturally to a bailout stenting approach of the side branch, which is the TAP technique, T and protrusion, as shown above. However, if the side branch access is very difficult, or if the ostium is extremely calcified and a very tight lesion is there and you want to secure the side branch first, you can still go with the inverted provisional approach, which is basically from the main branch into the side branch stenting, and then keeping access to the main vessel with kissing, then followed by pod. And the natural, obviously, bailout to that is the reverse tap technique with TN protrusion, which allows for adequate coverage of the entire bifurcation. The detail of the sequential provisional is very nicely outlined in the paper of the European Bifurcation Club, published in CCI in 2020. Basically, both branches are wired. The stent is placed from the main branch into the main vessel, and the side branch wire is jailed. Then proximal optimization technique is performed while the wire is still in the side branch. Then a third wire, or the wire in the main vessel, is used to rewire the side branch specifically from the distal strut. And that's very important for adequate reconstruction of the neocarina. And this is followed by a kiss, then a pod. So basically pod, kiss, pod, PKP. This is the result that one could get. That's kind of a reconstruction of the actual 3D rendering of the bifurcation without a side branch stent, also documented in the paper. If this ends up causing a dissection or a suboptimal side branch outcome, the natural progression is to actually use a side branch stent. So the recommendation is to place a balloon in the main vessel distal to the takeoff of the side branch in order to use it as an anchor in case we have trouble advancing the stent. Then the side branch stent is deployed with 1 millimeter protrusion into the main branch. Then the stent balloon is backed up and another inflation is performed only with the side branch stent balloon. Then the main vessel balloon is pulled back and lined up to have a nice kissing inflation at the bifurcation, followed by a final pod, which is to be done very carefully without including the protruded struts from the side branch in order not to cause any unintentional crush. This is the final 3D rendering of the tap technique, as you see very clearly in that paper. You notice the a natural rheologic, the natural respect of the rheology and the flow, and this is, in my opinion, the closest one could get to a natural carina without stent overlap, which is done usually in the Coulot technique. The inverted provisional, as we said, is reserved for anatomies where the side branch is very difficult and the operator wants to secure that. So the opposite is done: main vessel into side branch stent, then pot in the main vessel, distal rewiring, kissing, followed by another pot. Again, PKP. And obviously, this is the 3D rendering of what would look like. You can notice the difference in size between the main branch and side branch, which is obviously a challenge in situations where with significant diameter discrepancy. However, the newest stents have distension characteristics that allow them to be inflated even 2 millimeters or 1.5 millimeters more than its a nominal stent diameter. And obviously the bailout strategy for inverted provisional technique is the reverse tap, as you see in this diagram. So what are the pros? The reason why I like this technique is it's simple, it's straightforward, it's a natural bailout of the provisional technique, which most of us adopt in the large majority of bifurcations. One would not commit for 2 stents from the beginning. Even if it's an anatomy that requires 2 stents, you can still get by with sequential provisional, even in left main interventions. So in DK crush and Coulot, one will commit to a side branch stent from the beginning. With the tap, you don't have to. There's less carina displacement, in my opinion, when compared to the DK crush or Coulot. And basically, one of the biggest advantages is it's very practical. Less steps. You don't have to drop 20 balloons on the table to complete a DK crush or a Coulot with multiple stent recrossings and all that. All of that is not present in the tap technique. You just have to recross once, and you always have wire access to the branches, which is different than a DK crush technique. And one of the biggest advantages is obviously less metal overlap, no crush segment, no unnatural stent configurations, and all of that without missing the ostium. And one of the biggest advantages is that when patients present back with in-stent restenosis, which is obviously slightly higher in bifurcation stents, then taking care of that is much easier than if a DK crush or a Coulot presents with in-stent restenosis and multiple layers of stents. The cons are obviously the protruding struts. Even though with today's stents, the struts are so thin that endothelialization is not a problem, even with the presence of a drug. The discrepancy between the mother vessel and the daughter vessel is a significant downside. However, with most newest stents, the distension characteristics are so good that this is not a factor that is a major problem anymore. The side branch stent delivery is a difference from the other techniques where you secure the side branch, but with the balloon anchor technique in the main vessel, this could be done relatively easily. And very important to have the caution for the final main vessel pot, which can lead to crushing of the protruded strut. So very important to do that proximal to that. And this is my simple and hopefully straightforward technique that I would love to get your comments on. Thank you.